Well, good evening, everyone, and welcome. Thank you for joining us for tonight's webinar, the Liver Toolkit Project Participant Update. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water, and community, and pay respect to elders past, present, and emerging. I also extend that respect to any Aboriginal colleagues who may be joining us today. And as always, I think it's a particularly important topic and relevant to our care of our Aboriginal and Torres Strait Islander patients who, as you will find out during this talk, are disproportionately affected by liver cancer. My name is Penelope Elix, and I'm going to be facilitating tonight's webinar. I'm a GP, I'm working in Alexandria, and I'm one of the GP representatives on the Liver Toolkit Project Governance Committee. Tonight's webinar has been designed to update the practices and staff who have been participating in the Liver Toolkit project. The idea behind this presentation was to update you on that Liver Toolkit project and also to provide you with another learning opportunity associated with the project. We're aware though that some of you watching tonight are not participating in the Liver Toolkit project, and that's fine, all are welcome. For those of you who, even if you are participating in the Liver Toolkit project, are not fully across it, our presenters will be providing you with a brief refresher on what the project is, what it's about, and what our results look like so far. So don't worry, it will all become clear. So with this in mind, here are our learning outcomes. I'm just going to read them off. So the first was to describe the etiology and incidence of liver cancer or hepatocellular carcinoma and recognise the implications of increased rates over recent years. Then to apply the principles of HCC prevention and early intervention to actively participate in the Liver Toolkit project, understanding the protocol and processes involved. Number 3 was to recognise the outcomes of the project, the Liver Toolkit project so far. And number 4 was to remember best practice for patient management of viral hepatitis, fatty liver and cirrhosis for better patient outcomes with respect to HCC. This is the overview of what's going to happen tonight, and it's my great pleasure to introduce our speakers for this presentation. Now, we've tried to make this quite a collaborative presentation to reflect the collaboration that we've been happening between general practice and the liver teams at the hospitals for the Liver Toolkit project. So starting with Dr. Christy Kim. Dr. Kim is an advanced trainee in gastroenterology and hepatology working at St George Hospital. Dr. David Prince is a gastroenterologist and hepatologist working at Liverpool Hospital and RPA Hospital, and he's currently completing his PhD on improving the care of people with cirrhosis. The Liver Toolkit project is part of that. Then we've got Dr. David Baker. He's a GP who works at East Sydney Doctors, and he's the other GP representative of the Liver Toolkit project. And David's also a clinical advisor at Asham and has a special interest in HIV and hepatitis. And finally, we've got Associate Professor Amany Zekry, who is the head of gastroenterology and hepatology at St George Hospital. Associate Professor Zekry will be providing us with a specialist presentation in the second half of this webinar. So without further ado, I'd like to hand over to Dr. Christy Kim and Dr. David Prince to give us an introduction into the liver cancer part of this project. So thank you, Christy.
Hello, everyone. Thank you for joining us tonight. I'll be taking you through the liver cancer epidemiology and etiology. Then I'll be handing over to Dr. David Prince. So I'll move on to the next slide, please. So in terms of prevalence of liver cancer is the second leading cause of cancer death globally. That's after lung cancer. And HCC, hepatocellular carcinoma, accounts for the majority of those primary liver cancers, accounting for approximately 85% of the cases. Within Australia, HCC or liver cancer is the 11th most common type of cancer. Next slide. The incidence of HCC in Australia is growing, and after thyroid cancer, it is the second fast growing cancer. And the age standardized rates of HCC is rising from 1.8 cases per 100,000 in 1982 to 8.6 cases per 100,000 in 2019, as you can see from the graph towards the right. And a large proportion of these cases are accounted for by Australians who are born overseas, mostly in Europe and Asia. And men are affected disproportionately by HCC, and they account for 80% of HCC cases. Next slide, please. And unlike most other cancers, which mortality is falling or starting to fall, mortality for HCC is continuing to rise. And it is now the fastest growing cause of cancer-related mortality in Australia. Next slide. And this is illustrated when you compare it to the other types of cancers. As you can see from these graphs, the age standardized mortality for lung, breast, and colorectal cancer are all falling, as you can see by the downsloping graphs. Next slide. And as such, the 5-year survival rates remain stubbornly low for liver cancer, and it still sits at around only about 20%. Next slide. In terms of the distribution, from a national perspective, the geographical patterns for liver cancer diagnoses are dominated by the higher rates in the Northern Territory and far northern areas of Western Australia and Queensland, while Central and Southern Queensland, regional New South Wales, and southern parts of Australia have diagnosis rates that are lower than the national average. Next slide. In terms of etiology of HCC, majority of the cases, around 85 to 90%, develop in the setting of underlying chronic liver disease, most commonly in those with cirrhosis. And looking at some statistics from Victoria in 2012 to 2013, hepatitis C accounted for the majority of the cases of HCC, around 41%. That was closely followed by alcoholic liver disease, around 39%, followed by hepatitis B, 22%, and fatty liver disease, 14%. However, that was 10 years ago. And over the last 10 years, we have been seeing a relative decline in cases for hepatitis C, probably related to the advent of an effective cure for hepatitis C. And we are seeing a marked increase in cases related to fatty liver disease. And we are finding that along with hepatitis B, in people with fatty liver disease with advanced fibrosis, they can develop hepatocellular carcinoma in the absence of cirrhosis. Next slide. Looking at the indigenous populations, HCC affects indigenous populations disproportionately. And the relative risk of developing HCC has been quoted to be up to 6 times higher than compared to the non-indigenous counterparts. And the reasons for this are multifactorial. There are more hepatitis B within the indigenous population. The prevalence has been quoted to be up to 6% in remote communities. There is more hepatitis C in the indigenous population as well, up to 20% in some urban populations. NAFLD is also more prevalent in the indigenous population. Not only do they have more HCC diagnosis, once diagnosed with HCC, they also have poorer outcomes. Median survival following diagnosis of HCC is only around 64 days compared to 172 days in the non-indigenous populations, which is only a third. The reasons again are multifactorial, but largely related to access. They have poorer access to HCC screening, and only around 14% of hepatocellular carcinoma diagnosed in indigenous patients from a surveillance program, which means they are diagnosed at a later stage where a curative treatment may not be feasible. They also have poorer access to HCC treatment. Okay, I'll hand over to Dr. David Prince at this stage to take you through surveillance.
Thanks, Christy. So as Christy very well outlined, in most cases of liver cancer, there is an underlying risk factor, underlying liver condition, and that most commonly is cirrhosis. So there is a recognized prior condition where we can intervene to screen to hopefully detect liver cancers earlier, and there is good evidence now for HCC screening. It's one of the few cancers that have a proven screening test that is evidence-based. And randomized controlled trials have demonstrated that in patients who undergo regular ultrasound surveillance, that you get earlier HCC detection, and this is associated with reduction in mortality. This is most clear in the hepatitis B cohort, and this has been demonstrated on several occasions. There's also been a meta-analysis which has demonstrated a survival benefit from HCC surveillance. The method of surveillance, the main modality that's recommended in the guidelines is liver ultrasound, and this is recommended to be every 6 months. AFP also has a role in some guidelines as it may aid in detection, particularly for earlier lesions. If you move forward with the slide, this is a summary of the international guidelines. So these are all the major societies that have guidelines on this point. PASL is the Asian Society, AASLD is the American Society, and EASL is the European Society. And they all recommend screening in patients with cirrhosis. And these were with the modalities that are outlined, all recommending ultrasound, and then a PASL also recommending the inclusion of the AFP. If you move forward to the next slide, Australia has also now developed their own guidelines. Professor Zekry, who will speak later, was part of the committee for the HCC consensus, which has been developed recently by our national society. And we now also have guidelines within Australia of who should be screened for HCC. This consensus statement also outlines a lot about epidemiology, treatment, and other options for HCC. So it is quite a comprehensive document. So people who should be screened, anyone with cirrhosis should be screened. Because you can see here that their annual incidence of HCC is in the order of 5%. In most studies, when you get above about 0.5, there's a clear cost benefit from screening. So in this group at 5%, it's a very effective intervention, and it also has a mortality benefit as I've outlined. In people with hepatitis B, there's also other indications for screening. So Asian men over 40, Asian women over 50, people from Africa over 20, or indigenous and Torres Strait Islanders over 50. There is also another group that is recommended. So in someone with hepatitis B and a family history of first degree relatives, some of the guidelines do advocate screening this group as well. And as I've already said, that this is recommended with the 6-monthly ultrasound and an A plus minus AFP. Unfortunately, unlike a lot of other cancers, there is no current national screening program for HCC. We don't have breast screen or cervical screening or an FOBT program that's government funded. So this does rely on liver specialists and general practitioners working together to coordinate screening, but it is a cost-effective and also clinically effective screening program that we're quite passionate about in improving rates of screening in Australia. We move forward to the next slide. So HCC screening in NAFLD is a difficult group. As Christy already outlined, a liver cancer can develop in NAFLD even without cirrhosis. And on the other side of that, the majority of patients with NAFLD will not develop a liver cancer. In some estimates in the community, up to 20 to 30% of people will have NAFLD, and it's only a minority that go on to develop a liver cancer. So it's quite difficult at the moment to know who in NAFLD to screen outside of the setting of cirrhosis, and this is an ongoing area of research. We move to the next slide. But patients with definite fibrosis or cirrhosis, patients who are males, those with a lot of other metabolic risk factors, in some cases may be appropriate to consider screening as well. But this is really an individualized approach, and this is outside of the context of guidelines and in consultation with a specialist. We'll move on now. So that's the background to liver cancer. I think that's worth putting up because that was a large part of why the Liver Toolkit project was developed. We also received some funding to see if we could improve rates of diagnosis of cirrhosis and also liver cancer screening. So I'll hand back to perhaps Penelope first, if there's any questions, and then she'll probably introduce the next part of the talk tonight.
I'll now hand over to the two Davids. Firstly, David Baker, who's going to do us a quick refresher on what the Liver Toolkit project actually is, and use a case study to show everyone how it has worked. And then David Prince will come back on and show us some of the results that we've had so far. Thanks, David Baker.
Yeah, thanks, Penny, and thanks very much to Christy and David for the introduction. So the Liver Toolkit project has been running for the last year, about a year and a half, and it's a project overseen by the two main hospitals in the area, RPA, St George, and also the local PHN. And the aim of the project is to identify and improve outcomes of people with liver cirrhosis, particularly in regard to detection of HCC. And the second main aim is really a shared care aim. It's to improve the working relationship and communication between liver centres and general practice. So the first part of the project was really recruitment of practices, which has occurred. And there have been a few little hold-ups thanks to a certain virus. But the liver team run a tool, which we'll look at in a minute, called POLA. And this identifies at-risk patients who are then recalled. And at they attend clinics at the GP sites where they have a FibroScan performed and other assessments. And then if they're at high risk, they are referred to the liver clinic. So just next slide, thanks. Just talking about POLA, our site was a test site for developing this tool, which is, I think, really quite remarkable. So POLA is really based in Melbourne. It's mostly funded through various PHNs around Australia, and its purpose is to develop what they call a population level analysis and reporting tool that is used in a number of conditions, including cardiovascular disease. But in the Liver Toolkit project, it was really used to identify people at high risk for advanced liver disease. And it has a lot of functions. I'm just going to talk about one very briefly because I think this is quite remarkable. Probably most people are familiar with the APRI score, which is really looking a simple tool to identify people at high risk. So it just looks at the AST level essentially over the platelet. So if there's more inflammation or more liver damage related to low platelets, if the ratio is 1 or above, the patient is more at risk. But the histogram on the right side is of our practice. And this tool looked at the 13,000 active patients, and all the ones who'd had liver function, full blood counts in the last couple of years were analysed, and really quite remarkable numbers. And it performed this calculation in about 2 seconds and really produced this, looked at every patient, and out to the right, you can see people with higher APRI scores were identified. And if you click on the graph, it will bring up the patient list and you can then recall them. But there's only one of many quite amazing functions. Next slide, thanks. So there are 12 practices involved, 6 in each of the catchment areas of the RPA and St George. Next slide, thanks. I'm just going to talk, just to flesh it out a bit, I'm going to talk about one of my patients. He gave permission for me to talk about his story. He's someone who's been attending our practice for many years, 67-year-old male, a single gay man of Chinese ancestry. I think Chinese ancestry is actually relevant to the case. Regular low-level smoke and minimal alcohol. Both his parents died in the 80s. We don't know from what. Next slide, thanks. So his case history, long-term smoking, living with HIV for almost 25 years, fortunately had a terrible psychotic depression after a major assault. Because he had slightly raised transaminase, he had an ultrasound which identified fatty liver. And then he developed diabetes type 2 in 4 or 5 years ago. Next slide, thanks. So I've used the brand names just to, because that's what came up, but it's slightly simpler. So we look after his HIV, and that's all been very, very stable on the one tablet a day. He's needed ongoing treatment for his depression, although that's very stable, and he's on fairly standard medicine for diabetes. Next slide, thanks. I think this is quite relevant. When he walks into the room, he's not a guy that looks overweight. But his BMI is just 26. But we can see that his regular weight for many years was around 60 or slightly less. And then his weight jumped up 15 plus kilograms over the last few years. really perhaps partly coinciding with the introduction of his psychotropic medicine, which may have been a factor in his weight gain. Next slide, thanks. I might ask David Prince later on to comment on if someone with Chinese ancestry, if the BMI that we normally look at is appropriate. So it's quite a busy slide. We can just see he's got a number, his transaminase are slightly raised, repeatedly negative for hepatitis C, hepatitis B, surface antibody positive through vaccination, not from having had hepatitis B. Diabetes generally very well controlled. His HIV is all very well controlled. The virus has been undetectable for the last 20 odd years. When I put these slides together, I realized that his platelets had actually been falling over the years, which is a bit of a red flag for developing more advanced liver disease, which I hadn't registered. Next slide, thanks. So I might hand over to the other David now, so he was flagged to attend a liver clinic, and David might run through what happened next.
Thanks, David. And I think this is a fantastic case that demonstrates quite a typical patient we see with the liver toolkit. So very well, not having any symptoms of liver disease, and then on non-invasive tests has been flagged. So I do run through later exactly some of the features of these more complex tests, but on several of these measures, this patient's score was elevated. So his APRI was 1.98, which is well above the threshold we're looking at 1. It's getting up almost towards 2, which has even higher specificity for cirrhosis at a cutoff of 2. His FIB4 score was also elevated, as was his NAFLD fibrosis score. So on basis of all these measures, he was flagged for recall. And when we came out to the practice, we did a FibroScan on him, and unfortunately that was quite elevated at 19, which is consistent with cirrhosis, and this was a new diagnosis in this case. Next slide. So David obviously, did the right thing with him. As the first step, got a liver ultrasound for him to have another look at the liver. And in this case, there was still some features of fatty liver with some increased echogenicity. There was now a nodular contour to the liver and an irregular liver capsule, which is one of the early features of cirrhosis. Fortunately, there were no features of portal hypertension, no ascites, and also very reassuringly, no concerning liver lesions as well. So for his HSC screening, we haven't had anything of concern here. And then he was referred along to the liver clinic for further assessment. Next slide. And this is going through the process of the referral. So there's now a streamlined pathway to refer from general practice, and there is a specific template for the liver toolkit that you can access to send us a referral. I might hand back to David or Penelope about this, because there's a few slides on the referrals, and I've not actually done one of them from my end. So, they might talk through the steps, but part of this project was to have a streamlined referral for general practitioners.
Yeah, so I just use the stock standard letter writer in the practice software, but Penelope has more elaborate. She's using a more complex system. She might just talk about for a minute.
Yep. So, excuse me. David's standard system is the one that a lot of us are still using. The liver toolkit referral template came as part of the package of material that was sent through to the practices, so that we had a document that got auto-populated that we could send by fax straight over to the liver clinic at the relevant hospital. The other way that one of the sub things to test out with the Liver Toolkit project was using smart forms. And I just thought I'd remind people, if they are using them for RPA, that we can generate these referrals using smart forms. So this is your document view. You can see I've circled the little HL, which I think is health link. And when you click on that, you can open up a new file. I already had created him a test there, so this is a new one. So you click on the little new button there, and it takes you to a page with health link that allows you to select Sydney Local Health District Services. and you'll get some drop-down boxes if you go to gastroenterology and liver. Clicking liver and Royal Prince Alfred Hospital will then let you open up a referral window. Now, one of the things we did encourage participants to do, and if you are doing these for the Liver Toolkit project, is make sure that in the body of the referral, the words Liver Toolkit come in there so that the team know. And you can either submit once you've gone through those processes or preview. And if you go to a preview, you get a little picture of what's going to come up for that referral. So for those of you who are familiar with HealthLink and smart forms, please feel free to use them. For those of you who are not, there's been one recently and there's another webinar coming up by Sespen to talk you through your HealthLink smart forms. I'm learning to use them and absolutely love them. So I think it's really worthwhile having a play around and learning to use them. So I'll hand back to David Prince.
So yeah, we received a referral electronically, and then there was a little bit of delay with seeing him unfortunately in January and February with COVID, but then I've seen him recently in March. Very similar history to David. There weren't obvious risk factors for liver disease apart from some features of fatty liver, but I agree 100% with David that to look at him, he did not look overweight, and I think this is a trap even that I fall into as a clinician, that we are used to seeing patients on the heavier side that, people at BMI 26 to 27s you do get used to. And also for Asian patients, it is better to try and use a lower BMI threshold. So above 23 is said to be overweight for a person of Asian ancestry. So that is significant when looking at patients in this context. And also, we do also see patients sometimes with a condition referred to sometimes as lean NAFLD, so patients that still have a relatively normal body weight but can have NAFLD, and they may have a more aggressive phenotype, and this can be more common in Asian patients as well. So there were no other really red flag features of liver disease. Alcohol intake was very minimal. On examination, he was well, and there were no stigmata of liver disease clinically and no portal hypertension. So basically, my impression was that we had a man here with quite early compensated cirrhosis with no features of decompensation. And this is, if we are to detect cirrhosis, this is the stage we want to detect it at, because once people develop portal hypertension, they're then more likely to develop complications and come to hospital with fluid overload with ascites, more likely to have other decompensation events, more likely to develop a liver cancer. In this case, it was presumed to be secondary to fatty liver disease, plus or minus the influence of HIV and also the anti-psychotropic medications. Go on to the next slide. As part of the toolkit and just as part of standard care, we organised a liver screen. I think this is always prudent to do, David had done a lot already of this with the viral hepatitis, but I did the rest of this just looking at his autoimmune markers, did some iron studies. I think I might have even done a ceruloplasmin that's chopped off here somewhere, or depending on his age, this isn't necessarily needed over the age of about 55. But the reason why, you might ask why we do this, so liver disease often can hunt in packs, so people can have one clear cause of liver disease, but there may be a second or even a third liver condition there, and it may be treatable and modifiable, and again, it may help arrest progression and prevent progression towards decompensation. For instance, alpha-1 antitrypsin deficiency, we now realise it's not an all or nothing phenomena, and people who have a one gene mutation here may indeed be more predisposed to alcoholic or fatty liver disease. So it is always good to just screen for other things. That was done in this case. We didn't identify anything else. We gave him some education on cirrhosis. It was also linked into our hepatology specialist nurse who spent some time with him, and will also follow up with him on another occasion to do some more education. And we recommended he commence on regular screening. We've also discussed with him the possibility of endoscopy. So with the guidelines now currently say FibroScan more than 20 or platelets less than 100 would be when you would trigger to think about varices in a patient. So he's kind of on the cusp of those thresholds. The interesting is platelets are low without features of portal hypertension on the ultrasound, but he may well have subtle portal hypertension and varices. That's what I do suspect there. I think if there's not another clear reason for his thrombocytopenia, I think we may look at an endoscopy The next slide. So this brings up the idea of chronic liver disease in HIV. So patients with HIV are at increased risk of hepatic steatosis. Up to 70% of patients with HIV may have features of steatosis in some cohorts, and this compares to a background rate of about 1 in 5 to 1 in 4. And there is also a higher rate of progression to fibrosis. And chronic liver disease is now in some groups the second leading cause of death in patients with HIV, and also having HIV does increase your risk of liver cancer. So it's a group we are, particularly when we see NASH in this group or cirrhosis, they are a group that benefit definitely from HCC screening. Next slide. So these are some of the notes David put together. I think they're perfectly apt. I think this is a brilliant example of shared care. I think this shows that in early compensated cirrhosis, patients won't have symptoms, and it's so difficult when they're presenting with a lot of other complex medical conditions that it may be just asymptomatic sitting there in the background with some mildly abnormal LFTs, low platelets. And this is why non-invasive tests can be useful, or tools like the Liver Toolkit to highlight patients who may be at increased risk and may benefit from cirrhosis screening. I'll hand over to David as well to see if there's anything else he wanted to add on the case, but I think it does demonstrate how the tool can work well in practice.
Yeah, no, I'm delighted that this project is running, and I think thanks to this project, this patient was identified. I feel a little embarrassed that it's this sort of happened under our nose, or under my nose anyway. That I think it's all the comorbidities can obscure the diagnosis, but also I think it's important to, in general practice, to make sure we use our GP management plans and mental health plans to coordinate and optimize services, and as well ensuring things like vaccinations and other preventative health care occurs. So thanks for your involvement, David.
All right, next slide. So yeah, I'm going to run through just some of the results as well. These are preliminary data, and as David said, we have been a bit COVID affected, but I still think we have enough results that kind of illustrate what we're looking at with the project. So in the interest of time, I'll spend about 10 minutes going over this now. So next slide. So the Liver Toolkit project, as we said, is in 12 practices across the PHN. In terms of the size of those practices, between all of the practices, we have over 130,000 active patients in those practices. So they're patients that have been seen in the practice in the last 2 years. Roughly about a third of them have tests that mean we can draw their results into the Liver Toolkit. So that's a population of about 46,000 patients. And we've individually visited the practices throughout the project and run the tool 31 times. We're specifically focusing on the tool at the moment on the APRI greater than 1, the FIB4 greater than 3.25, or high risk NAFLD, which is a combination of their age, their other risk factors, and their NAFLD fibrosis score. I'll spend more time explaining exactly what these measures are in a minute, but they're the ones that we're focusing on at the moment, and that's already identified quite a few patients. Next slide. So these are the non-invasive tests, and we've chosen to use tests that are available from standard lab tests and standard data that is available in the practice software. There are other proprietary tests that require a special blood collection, but these tests we've used here are quite simple. So on one end, one of the most simple ones is the APRI, which, as David has outlined, involves their AST and platelet count. The FIB4 also incorporates their ALT. The NAFLD fibrosis score does incorporate their weight, if they're known to have diabetes, and their albumin level, and also their age. So as they become more complex, their accuracy may increase, but then the number of patients you catch with them will also drop. So these are kind of rough figures, but roughly about 35% of patients will have an APRI, but it's only about 20% that have a NAFLD fibrosis score when we run the tool. So it is a bit of a trade-off between more inputs to make it maybe more accurate, and then how much data do you need. So we'll move on to the next slide. So to begin with, at the start of the project, we did a snapshot of our practices just to see where they were at. And then we've been running this again. This report gets run every month or so and captured by the PHN, and we will look at it again finally at the end. So the existing rate of cirrhosis at the start varied from about quite low at 0.01% up to almost 0.8%. This does rely on diagnoses of cirrhosis in the management, in the diagnoses, and also it screens and extracts words from the clinical notes. So it relies on it being identified in the notes, but this is our baseline level of diagnosis. We will, as I said, we remeasure this throughout the project, and we're also recording new diagnoses of cirrhosis and advanced fibrosis. And we're hopeful to see if the liver toolkit may help us find new patients and increase the diagnosis of cirrhosis. Next slide. In the interest of time, I won't spend long on this, but we also capture background rates of things like NAFLD, hepatitis B, hepatitis C, and alcohol misuse. And this does vary between our practices as well. So we have one practice has quite a bit of hepatitis B at 4% of all their patients. We have one with high rates of hepatitis C. NAFLD is variable, but anywhere between 1% and 6%. This is probably an underdiagnosis of NAFLD, I'd say, in that this also relies on a diagnosis being entered. But this is quite significant when you think about it. 1 in 20 patients in some practices with NAFLD, and in overseas, sometimes even double and triple the rate of this has been described. So we'll move forward. So coming to the actual patients we've flagged for recall. So far with running the tool about 31 times, we've found 878 patients without a diagnosis of cirrhosis who've been flagged as at risk and have been identified for recall for FibroScan assessment. We're in the process of recalling these patients now. The response rate does vary, but has been in the order of about 40 to 50% for most practices. And so far we've seen 113 patients who've been assessed, FibroScan, consented to use their data, and enrolled in the project. There's a further 17 patients we've seen and have done a FibroScan on based on a direct GP referral. So we also do accept patients if the GP has a clinical concern about someone. When we're there on the day, we can have a look at this group as well. So moving forward. So this is the characteristics of the patients, this 113 that we've assessed so far. The median age is 62. There is a male predominance. The BMI, median BMI is 27. There's actually not a lot of alcohol intake when surveyed, and that's perhaps a little bit surprising. And there is not a lot of Hep B and C either, but we are picking up high rates of diabetes and dyslipidemia. So this is in fitting with fatty liver. I think that would be the predominant condition we are encountering when we're reviewing these patients. Next slide. The reasons for recall. So this 16 have been scanned for a high APRI, 10 for a high FIB4. That is a high FIB4 without an APRI. So many patients will have both, but an independent high FIB4, and then 48 with high risk NAFLD as well. And there's a few that the exact reason we're still kind of completing the data, but they're the ones we have. Next slide. In terms of the outcomes so far, so these are the FibroScan results. So roughly a quarter to a third of them have a significant result that needs ongoing follow-up. 6 of them have clear cirrhosis, and these were all new diagnoses. There was a group that 10 that had clear evidence of advanced fibrosis, and this group also, it's unclear exactly what they have, because they've had a high non-invasive blood test and a high FibroScan now, so that this group often need to be watched quite closely. They may still have cirrhosis, so people in this range may still be cirrhotic, but do need to be monitored quite closely. And then there's a group that are indeterminate as well. And all of these have been linked to, or been recommended to be linked for follow-up. And in about the other 2/3 to 3/4, we've had a good result, and we can reassure them and discharge them back to their general practice with a plan for lifestyle modification as well, or other interventions as needed. So moving to the next slide. In terms of the other outcomes we're interested in, so HCV surveillance, we've identified 17 patients through the toolkit in whom HCV screening would be indicated, and roughly a half of these prior to the toolkit were receiving the screening, and the other 8 we have been able to get them commenced on screening. So hopefully in this group we hopefully they will never develop a cancer of these 17, but if they do, hopefully we'll pick it up at an early stage where it is curable. In 16 patients, we provided them education about chronic liver disease. This is generally the cirrhotic group or advanced fibrosis with risk factors or other liver conditions, and we can administer education at the time. We often bring our nurse specialists along who can give resources as well to the patient. And then in terms of referrals to the liver clinic, we've referred 19 patients so far have come through the liver clinic and been seen as well. So we are starting to see patients at the other end of the project as well. Moving forward, unfortunately, COVID has had a bit of an effect. So these red zones are where we've been definitely locked down and not been able to come in. And other times as well, there's also been restrictions around PPE and all the other things that were with COVID. So it's been a bit of a tough year for everyone, not across the board. But hopefully now we're back on track to complete the rollout, and that's our recall, and that's the aim over the next 6 months or so. Next slide. In terms of other aspects of the projects as well that are worth mentioning, there will also be a qualitative analysis at the end to assess how the project has gone. We're looking at getting 360 feedback, and there will be invitations to get GPs, practice staff, hospital staff, patients who've been in the project involved to give their feedback to see what can be improved going forward. There may also be some refinements to POLA if the pilot's successful, to make perhaps the tool more user-friendly, to have less instruments, and maybe even if it's successful, have a rollout to other practices. Next slide. So the liver toolkit in terms of the outcomes, so we're hopeful it will establish a better estimate of the prevalence of liver disease. We will hopefully be able to estimate the rate of diagnosis of cirrhosis within the community. We'll understand the relative frequency and causes of liver disease within the PHN. We may hopefully improve HCC screening, and we'll also assess the utility of this approach in improving diagnosis and linkage to care. Next slide. And then what's next? So as I said, you'll be seeing more of us hopefully in the next 6 months or so as we come out to complete the data collection. We will then do a more formal analysis, both quantitative and qualitative, and the PHM will also do an analysis with some of their data. We prepare a final report, and then we'll look at whether this would be suitable for further refinement and broader implementation. So I might stop there. If there's any questions about the project or anything I've said, I'll happy to take them. Otherwise, I'll hand back over to Penelope, who will introduce our next speaker.
Great. Thank you to David Prince and David Baker for that part of the presentation.
Much, Phil. Thanks, everyone. And I know I'm keeping everyone late now, but you've heard very good presentations and represented by cases. By way of introduction, as Penelope said, I'm head of gastroenterology and hepatology at St. George Hospital. And some of you may know that we've had a very active interest in terms of screening the community. And we've published in this area, and now that we're part of the Liver Toolkit, which we believe is a very important initiative. And the whole mark of doing this is trying to offset the burden of liver cancer. You've seen slides about the crisis that we're dealing with in Australia in terms of the rising burden of liver cancer. And it's going to be a collaborative effort to try and stop that epidemic of liver cancer in Australia. And that basically was behind forming the Australian recommendation for the management of liver cancer, which was published recently. The reason that we can actually make a difference in liver cancer, because probably liver cancer is one of the cancers which its risk factors are either preventable or modifiable. So if there's hepatitis B, like chronic hepatitis B, we can vaccinate against hepatitis B and prevent, liver disease from Hep B. And a country that made a huge difference in this area and published is Taiwan, for instance. And they were able to offset the burden of liver cancer, having been first in liver cancer, now the last in liver cancer by their vaccination program. We have effective antiviral therapy for hepatitis B, so it's a matter of identifying these patients and putting the appropriate patients on treatment. Hepatitis C treatment now is more or less a piece of cake, to be honest, for the appropriate patients. For 8 weeks, one tablet can cure hepatitis C virus, so it's a major advancement in treating Hep C. The problem is non-alcoholic fatty liver disease. We have not made significant advances, but it's important that we identify the risk factors, because we can modify the risk factors and reverse some of the liver damage. And of course, alcohol was a huge problem. But when you look at this slide, yes, most of the factors which can lead to liver cancer, as you can see, we can either reverse them or modify them. So that's why we are actually very passionate about the liver toolkit, because that's where it actually have a key role in this sort of area. Next slide. And when we come to talk about Hep B vaccination, I think it's very clear there are the groups, like everyone should be vaccinated against hepatitis B, to be honest. And we should be seeking to be actively vaccinating those who are not vaccinated, especially those who live in high-risk areas or are in high-risk population. Next slide. And in the next few slides, perhaps look at the burden of viral hepatitis and NAFLD, but at this time of the evening, I don't want to, my intention is not to give a huge talk about the treatment of viral hepatitis and so forth, but perhaps to highlight and to carry on from what Christy and David have spoken about, is that we have a problem, and unfortunately we've added COVID to this problem, which basically magnified what we are dealing with now. So we are aware that, you know, viral hepatitis is the key reason for liver cancer. 78% of liver cancer is due to chronic hepatitis. And that actually can kill more than 1.34 million per year worldwide. And that's the WHO findings. There are recommendations from the WHO that we need to treat a large number of infected patients by 2030. And certainly that's a very optimistic goal in the current COVID climate, but the whole idea of this is to offset the burden of death from liver cancer. Next slide. And it's clear that if we treat Hep B and C, there is enough and enormous amount of data to say when we eliminate the virus, we reduce the risk of liver cancer. It's important actually from this slide to take home, we are reducing the risk, but we're not eliminating it to zero, especially in patients with liver cirrhosis. So yes, we identify, we treat them, but if the fabric of the liver is damaged with liver cirrhosis, there are recommendations that we continue them in surveillance program for liver cancer, unless there is some evidence that there is reversal of the liver disease. Next slide. And as I said earlier, COVID-19 had really distorted our, or really halted our effort. Like, you know, most of us were really going full on with the liver toolkit, visiting centers and so forth. But understandably, you know, general practices became overwhelmed with COVID vaccinations and other initiatives. And it became too dangerous for us, for instance, to go into the community, which was a huge initiative for us to screen them for hepatitis C and B and to vaccinate and so forth. So all these activities, unfortunately, just stopped or slowed down over the last 2 years because of the COVID pandemic. When you look at publication, what happened in other places around the world, it's clear that, not surprisingly, on par with what's happening in Australia. So the number of patients who started treatment for hepatitis B pre-COVID compared to post-COVID have declined by 17%, and probably in some areas more than 17% because of the factors I've just spoken about. Next slide. And this paper was published recently, which is actually quite scary. It's modeling the impact of COVID on treatment for hepatitis C. And understandably, many centers have just dropped the bundle completely in terms of screening for hepatitis and in terms of treating hepatitis C. And from there, the projection says that if we continue at the same rate we're doing now in terms of not being able to screen and treat for hepatitis C, which is a very easily treatable disease in a certain population, then we will definitely cause more than 72,000 excess liver Hep C related liver deaths and excess more than 44,000 excess liver cancer cases. So that's a huge burden, and that's in 110 countries who were screened and collected data from, and these countries, among them European countries, American countries, and African countries. Australia was not part of this country, so hopefully we're not going to see that black side of the pandemic impact on hepatitis C and hepatitis B. Next. And when we look at treatment uptake in hepatitis C in Australia, it really, as you can see, peaked nicely in 2016 when the drug DAAs were first approved. But as we went throughout the year, especially with the start of the pandemic, it had declined significantly. So this is really where we need to be proactive in terms of looking at the cases of hepatitis C and screening for liver disease and treating. Otherwise, we'll be part of the countries that we're going to see a huge mortality from hepatitis C related liver disease and from liver cancer. Next slide. So, and now, as I said earlier, tackling Hep C in Australia is so much easier. As we said, we have drugs which is pan-genotypic. We don't even have to test for the genotype. One tablet for 8 weeks to 12 weeks can eliminate the virus. And linkage to care and community models of care are very well established in most local health districts. So there are many incentives and initiatives to go ahead and treat as many patients as possible for hepatitis C. Next. And certainly in the COVID era, it's a challenge. And there are some strategies, like if we have, for hepatitis C, for instance, if we have somebody from a high-risk area and we worried that they're not going to come back for after Hep C antibody, maybe just test them straight to Hep C RNA. There are now point-of-care testing machines that St. George is going to acquire one of them, which we can just with a drop of blood, we can test for hepatitis C and hepatitis B. And that would be very useful in terms of screening safely the population, especially those who don't want to come back for the results in a hospital setting, but we can link them in the community for treatment and so forth. So we're trying to adapt and move with the flow, especially with the COVID, in terms of trying to screen and identify patients as fast as possible who would benefit from treatment and elimination of hepatitis C and B. Next slide. So this is for Hep B and C, and I think it would be good if somebody still has some energy to talk after we finish to see how the COVID has impacted in terms of screening for hepatitis C or B in the practice, and whether the liver toolkit has got a role now to re-energize the premise of looking for patients with liver disease from Hep C, B, and NAFLD. I might just give 2 slides or a few slides on non-alcoholic fatty liver disease, because this is our, I call it the Australian catastrophe. Because of the rising burden of liver, of obesity and diabetes in Australia, in most areas, including my specialist colleagues, very well trained in checking for complications related to diabetes, such as kidney, heart, eyes, and so forth. But when it comes to the liver, it's the most neglected organ in terms of screening in the context of metabolic disease. And that's actually been shown in a recent publication as well. So let's think of the liver when we have people with diabetes, hypertension, hypercholesterolemia, because liver cancer is really rising to a very scary end in patients with non-alcoholic fatty liver disease. Next slide, please. And the spectrum of non-alcoholic is from steatosis to, which is fatty liver, to steatosis and inflammation, which we call NASH, to liver cirrhosis, and then to liver cancer. And hence, you know, we need to stop it at some stage, and we can interfere at any stage before liver cancer and be able to reverse a degree of liver injury, which would stop the development of liver cancer or reduce the risk rather than stop. Next slide. And the patients that you really have to pick in clinical practice and be concerned about are the ones who have multiple metabolic risk factors. So this is a nice study that says the more metabolic risk factors the patient have, the more the risk of liver cancer. So with about 4 metabolic risk factors, they have now, you know, almost 26 chance of having liver cancer. So diabetes is one, hypercholesterolemia is another, hypertension, and so forth, and obesity. So the additive risk, if you see this patient, these are the patients who are just at risk of having liver cancer and need to screen them for liver disease. And this is where the liver toolkit had come very handy. In fact, in our area, which is in southeastern Sydney, we're finding more liver cirrhosis in the context of NAFLD. And you will see one of the publications that we've published recently. We screened 800 patients with a fibrous scan in the community, and 10% of them had liver cirrhosis. So that's the precursor for liver cancer. And the majority was due to, again, NAFLD, non-alcoholic fatty liver disease. So we have a problem with non-alcoholic fatty liver disease in Australia, and we need to identify these patients earlier than later. Next slide. And not all patients with NAFLD are the same. As I said, the more risk factors, the more metabolic risk factors, the worse. So patients with simple steatosis with normal liver enzymes, they don't have to, we don't have to panic about them. And certainly there is a health pathway for patients with NAFLD, which has been developed, and I think it's available. And there are a selected group of patients that we need to be alarmed or need to be careful about, and these are the ones who need to be referred. Mostly they are in age over 65, some ethnic backgrounds, and they have multiple metabolic risk factors. What do you do with these patients, or why do you refer them? Because we need to reverse whatever risk factors we can reverse. If it's diabetes, we need to control it. If it's hypertension, we need to control it. Hypercholesterolemia, obesity, and so forth. And there are multiple clinical trials for NAFLD that they can be enrolled in just to try and offset some of the hepatic inflammation in this context. Next. And that brings us to, is NASH reversible? Because I had somebody saying to me, why should I send a patient to you? That was actually an endocrinologist. What are you going to do? You know, you don't have any treatment to offer them. Next. Treatments are emerging, but the key thing to take home message that any extent of liver disease, or to a certain extent, can be reversed. And in this study, for instance, after bariatric weight loss, they found that we can regress inflammation, we can regress fibrosis. So we can regress many markers of liver injury in the liver with weight loss. And that can start, you know, by if they say they lost about 5% of their weight, they can start achieving some improvement. If they lost more than 10% of their weight, they can achieve even fibrosis regression. So we went through medicine in the past saying that, you know, cirrhosis and fibrosis is not reversible, but now enough data from multiple diseases, Hep C, Hep B, and now NAFLD, that fibrosis, we can regress it. And 10% of weight loss can achieve fibrosis regression in a certain group of patients. So that's why it's important to identify them and act on them. Next slide, please. And certainly there are multiple agents to treat NAFLD in development. Among them are the drugs used for diabetes and weight loss. And, you know, semaglutide is becoming the new kid on the block. I think everyone is taking it who wants to lose weight and so forth. But regardless, these agents have been shown, if you go to the next slide, please, because I'm not going to go through this at 7 p.m. These agents have been shown that they can achieve resolution of NASH, some of them fibrosis improvement, in addition to many improvements in the metabolic profile from triglycerides to LDL and to diabetes and so forth. Next slide. So the take-home messages at this time of the evening, GPs can have a significant difference and can make a significant difference in terms of controlling the rising rate of liver cancer in Australia. And we really, as the first slides and as Christy and David have shown, the incidence of liver cancer and death from liver cancer is rising in Australia because it's usually in about 60% of patients is discovered in the late stages. Late stages meaning it's too late to intervene. If we actually discover it earlier, we can intervene, can liver transplant, surgical resection, so we can introduce curative therapy. But unfortunately, more than 60% are found out late because there is no proactive screening program for them. And hence, this is what the liver toolkit is important. Next slide. And we have to focus on reversing, as we said, whatever is reversible, like chronic viral hepatitis, metabolic risk factors, alcohol, and surveillance of those at risk with or those who have liver cirrhosis. We definitely surveillance. If you go to the next slide, in many studies have been shown to reduce the burden of liver cancer and reduce death from liver cancer, because when detected earlier, we can do something about it. But when they come with 5 lesions, 6 lesions or more, then it becomes too complex to treat them. So the earlier we detect cancer, the better the survival rate in this situation. Next slide, please. And once it's detected, and this is just to highlight that the survival is improved if we actually adhere to screening programs. Next slide, please. And once detected, the management of liver cancer is quite complex, but we can't go anywhere without a multidisciplinary team for managing liver cancer. And most of you would have dealt with the multidisciplinary team, and certainly the general practitioner of primary care is part of this team that manage patients with liver cancer, given the complexity of liver cancer. So, I mean, attending this session is very important, and thank you for attending it. Being part of the Liver Toolkit and being involved in it is very important because you are part of this team. So thank you so much. And I would like, actually, if you go to the next slide, just to take this opportunity and thank the nurses and the doctors who goes to the general practitioners and try to help with the liver toolkit and screen, and from both St. George and Royal Prince Alfred Hospital. And I think some are taking it backstage, but definitely we should thank them, like including Nathan McGarry, who's one of the nurses who's been leading the program, the liver toolkit at the Southeast in Sydney. So thanks everyone.
Thank you, Professor Zekry. That was a great presentation and made me a bit nervous, to be honest, about those impacts of COVID and the delays in screening that we do in general practice. So I've certainly got a couple of questions to ask you myself, but we've got one now. So we're going to go on to our sort of panel discussion. So if you do have questions of Professor Zekry or the Liver Toolkit team, Christy, David, please pop them in. We've got plenty of time to go through some questions. One came through, thank you very much, from Charles Avadia, who said, in a general practice, what do studies show are the number of patients of concern, say, per 1,000 patients on our books? So I wonder if perhaps we could ask maybe Professor Zekry first. It might be, I don't know if that's easier to break down into, say, estimates of NAFLD in our community or estimates of hepatitis in our community. Are you able to give us an idea of what proportion might be sitting in our practice that we don't know about?
Yes, I can. In fact, I published on this. So
excellent.
We've done a project in NPS with NPS where they used, is it called Medical Director, the software that
it's MedicineWise, I think is the NPS software. Yeah. So they basically did some screening in terms of patients who've been identified even as hepatitis C, and did not go on to do an RNA test, and that was, you know, a large number of patients among the practice that were, I think there were more than about 40% of patients who were identified as Hep C and did not go back to receive any specialist service or subsequent RNA. So I think there's a proportion of patients sitting in GP practice and even the community, but antibody alone, as you know, is not enough to say that they have hepatitis C, like, you know, but they did not have a PCR to rule in or out whether they have Hep C. That's for Hep C. With NAFLD, it's a party, like we can call it the NAFLD party. You can ask how many diabetics do you have in your clinical practice, in your GP. So you can tell me about what 80% of your patients will have diabetes, hypercholesterolemia, and hypertension. Like there'll be a large proportion of patients who have this metabolic profile. So each of these patients who have this metabolic profile is likely to have a degree of liver disease. In one study in Melbourne, which, you know, a consultant actually sat in the GP practice, and they found about 80% of patients who have this sort of features have a degree of liver disease. Pretty significant number. I suppose it ties on to a question that I'd like to ask, which was really around helping GPs, you know, the impacts of COVID that you outlined on hepatitis C screening and the like of COVID. You know, in general practice, I think we're all pretty fatigued and are trying to find that way to re-engage our patients into preventive screening, which we've certainly had a challenge in terms of getting them in to do cervical screens or getting their mammograms done, things like that. What advice would you give to the GPs on the call about maybe how to look at liver disease as one of those important things that we've got to keep front in mind? How would you encourage us to kind of prioritize that in amongst all the other things?
Yeah, it's a good question. And you know what, I don't have a specific advice. You know, my husband is a GP, And I try and hammer him about, you have to look after every patient as if they have liver disease. But it's overwhelming, the GP practice, as he said, what's they've been going through recently and the burden that has been put on the general practitioners with respect to vaccination and the COVID situation and so forth. But I mean, this session, the initiative is to raise awareness of liver disease. So what I would do, pass this awareness, like there has to be some satellite sort of pass on awareness to other general practitioners about liver disease. It has to be embedded via recurrent education and alarming. And everyone who's attending today, I'm almost certain they would have had somebody who had extensive liver disease or liver cancer, and they can see the suffering. Heart attack, people die suddenly, or the life liver disease or chronic liver disease, the death is slow and painful, especially if they're not eligible for liver transplant. And it can be prevented, and I think that's what needs to be embedded in every practice, that every patient who has metabolic risk factors may have liver disease. So take home message. So please raise this awareness among other colleagues. I am raising it among my specialist colleagues. As I said, my endocrinologist was not very, excited about sending us NAFLD patients. And second, the high risk population, or screen everyone for Hep B and C. There was a study that suggested, because we dropped the bundle internationally in terms of screening Hep B and C, that maybe we should put screening programs in the COVID vaccination hubs, that everyone who's coming in to have a vaccination, maybe we should do a point of care testing on them so we can start screen and eliminate. So it's, we need to start thinking outside the box, and it will be helpful that if you have input into it, I can't tell you, you have to tell me now how to do it, to be honest, because you're overwhelmed and we're overwhelmed. So we just need to give each other ideas now.
I certainly think that those statistics that Christy and David showed us about the rates of those common cancers that we screen for going down and the liver cancer going up, certainly one of the things that came into my mind looking at those was sort of saying, when I'm going through, when people are coming to see me to check that things are up to date, is to say cervical, breast, bowel, liver, like adding it in as something that we think about in terms of cancer screening and cancer prevention, just including it in that little bundle. Perhaps Christy or David, have you got any thoughts about how we can encourage GPs to keep it front of mind, looking after livers and screening?
I think also abnormal LFTs is something to always watch for. I mean, maybe it's my practice, but almost everyone has mildly abnormal LFTs, but not just tolerating them and ignoring them and just thinking, oh, that's NAFLD. So I think if you do have patients in that context, sometimes using these non-invasive tools like the APRI, like a FIB4, which are hopefully will become more and more integrated into practice software, that there's moves that at some point pathology companies might even start kind of putting these on the bottom of some of the reports, so that there are these non-invasive tests to kind of stratify people's risk. And if they have these elevated non-invasive scores, they're the patients that, like Amany was saying, you may need to drill down on more. You may need to get really aggressive about the risk factor modification. It is a spectrum, and I think we're moving, hopefully over the next 5 to 10 years, that we'll have more sophisticated ways with technology to sort out the big NAFLD group to see who is high risk, and then we'll also have more sophisticated treatments, because as Amany said, there are now multiple drugs in phase 3 clinical trials, and some of them even show promise at regressing or reversing fibrosis. So it'll be about detecting NAFLD, then kind of stratifying NAFLD into the ones that are at higher risk, and then intervening to reverse that risk factors and hopefully prevent them ever getting cirrhosis or a liver cancer.
And I think I really enjoyed Amany's presentation, and also I think we now have a lot more tools. I think everyone's Ozempic, semaglutide has been a phenomenally useful drug, and I think suddenly we don't have to be as pessimistic about weight gain as perhaps we used to be. So that's very encouraging. One thing, recently I've had an experience of, unfortunately, reinfection with people with hepatitis C. And I think it's, again, these are people under our noses who were living with hepatitis C, were cured a few years ago. And I guess not retesting people periodically with hepatitis C PCR. I've had 3 patients in the last few months who seem to have had reinfection, which and they hadn't presented as being at high risk. So I think we have to keep thinking about viral hepatitis. One quite specific question I would like to ask the specialist is, the guidelines about ultrasound screening don't say much about older Europeans background. They're mostly focused on people with African or Asian ancestry. But what do you recommend for, say, someone who has a long-term hepatitis B that's with a low viral load, undetectable viral load, say, and immune control? Should they be screened with 6-monthly ultrasounds if they're, say, over 50 or 60?
Yeah. David, do you want to answer?
Yeah, so there are a couple of approaches to this. So I generally would, if they're of Eastern European background, because there is data that they still are at higher risk genetically of liver cancer. There are also some tools you can use. So there's a page B score where you put in other features that look at their risk of liver cancer in the setting of Hep B. So you can stratify people, and if they come out as high risk, some countries go to screening based on that approach. But I'm a bit more liberal with the Asian male, Asian female. I mean, I think if you've got kind of Middle Eastern or Eastern European, I generally am more inclusive, particularly if there's a family history or other things that will push me towards screening. What's your approach, Amany?
Yeah, so I just follow the guidelines, regardless if they are over 50 males, Hep B surface antigen screen. I think it's important. It's actually a very good question. Thank you, David. Like, there are two, like we spoke about liver cirrhosis being the precursor for liver cancer. And although rare, there are 2 groups of diseases which, more common than the others, that liver cancer can happen without liver cirrhosis. And these are Hep B and steatosis, significant steatosis. It doesn't say that we have to screen, of course, every patient with NAFLD, or it doesn't say that we have to screen all patients with hepatitis B, but certainly if they're over 50 surface antigen, they go through a screening program. So I screen them.
Over 50, well, that's nice and easy.
I wonder if I might bring us back to the liver toolkit. Certainly, sorry, when my microphone started having problems, I'm not sure how much of my comment about the lessons that participants might have learned throughout the project. And one of mine certainly was about the importance of adding diagnoses to the past medical history list. So popping those diagnoses of cirrhosis when they're there, popping the hepatitis C and hepatitis C treated or eradicated, so that we actually know when we run tools like this, we identify these people that we either know they have these conditions, but we just haven't added it to the list. So really looking at coding. I was wondering from the people that have been running the toolkit, David, Christy, and David Baker, as well as the other GP here tonight, what sort of takeaways for the GPs and their practice staff, any sort of lessons gleaned through the process so far?
I think
I have a question after, yeah.
The other thing about the diagnosis, it's kind of related, but I saw one practice do this, which I thought worked quite well. They actually, you can put the reminders in, and they put the reminders in for the liver cancer screening. So I think if you've got someone with cirrhosis, I don't know if that automatically happens or if you manually do that, but using the tools in the software, because it's so hard to remember where everyone's up to with everything, but you can, I think, set reminders to do the screening every 6 months, and then they'll flash up in red that it's overdue for the liver cancer screening. Because it's so difficult to 1 or 2 medical conditions to track everything. If someone's got multiple, I don't know how GPs do it, but technology.
Yeah, so
And
using the software, certainly best practice and medical director definitely have our reminder functions where we can add those things, fasting bloods, liver ultrasound, whatever they might be. So definitely using our software to our advantage. Amany, you had your hand up. What else have you got to add?
No, I actually have a question. Sorry, so you can finish this, but I have a question. So it's actually
Well,
to a GP.
Well, I'll just see if Christy or David Baker have anything else, any little tips that have come out of participating in the Liver Toolkit project for the GPs and their staff that are listening tonight. Sorry, I should say GPs and practice nurses and practice managers. I'm not sure the makeup of the audience tonight, but I know that there's a lot of staff involved at the various practices.
I think you've made some very good points, Penelope, about using the software. I mean, it's important to put everything in the problem list because that's where all your searches are based, and trying to keep it as accurate as possible. One of the problems is the coding in the used in the software programs is not ideal for HIV, hepatitis B, and hepatitis C, and that's something that needs to be fixed with the software companies. The other very big problem is actually the which we found with tools like POLA is the pathology labs don't send hepatitis C results particularly in a way that can be easily read by the by POLA or other software systems. And I don't know if that's been Amany, I don't know how you deal with that in doing your studies. I think there needs to be, the pathology companies have had the ability to code properly and they, for some reason they don't. And that's been a major problem with things like POLA. You can't pull out hepatitis C PCR results.
Yeah.
And similarly with ultrasound, I mean, we've had the same thing that people's care, and I find this a big problem. It can be quite fragmented. Patients sometimes go to 3 or 4 different radiology practices and not the same one, and you may or may not get a report in one format, and that's sometimes quite hard to track when we're looking at files, or they might have their ultrasound at the hospital and never, the report never comes to the general practice. So I hope the systems get better in the future for that, but that's been another hurdle we've hit at times, just trying to track down exactly where people have had their scans done and coordinate them all together to make sure that they've been, appropriately timed and that, make sure there's nothing worrying on them as well.
But I think it's very important to put the recalls in because that's as soon as we see the patient, because unfortunately I've seen people develop HCC who've just been 3 months late with their ultrasounds, and it's trouble with all recalls. By the time the patient has the test, they're a month or 2 late, and then you put the recall in and you get creep. So it goes beyond the 6 months. And I think HCC goes from being invisible to being untreatable very quickly.
Correct. Yeah, good point.
And I'll go to Amany's question. I'll just remind everyone we've got just a few more minutes before we will log off tonight. So if there are other questions or things that people want to comment on, please pop them in the Q&A. But let's see what Amany has to ask.
No, I actually wanted to ask you and David, and other GPs present, what would be the best way to follow up, the Liver Toolkit? From us, it will be important to talk about the challenges as well. Sometimes you find the patients in the software, and then it's the process of calling the patients and who should be calling the patients. And that also need a little bit of planning, discussion, and GPs have to be comfortable with this process. So that's if you have any sort of advice or recommendations for us, that would help us in terms of the follow-up, because it's just not enough to identify the patient. The subsequent steps can be very challenging.
And I think that's probably one of the will come out in our qualitative analysis that the project will undergo, because certainly there are those sort of various levels of implementation when we're rolling out projects like this. Like you said, you know, it's pretty easy for someone to come in and run a tool on the POLA. It's another matter once you give that list to someone who's going to do that recall, and are the patients going to be happy to participate? Are the doctors or nurses happy to do the recall phone calls? We've encountered a lot of different kind of barriers along the way, that kind of just flag that general practices are busy places, and you know, you add another thing to the list of, oh, I've got to recall the patient for this too. So definitely I agree that I think it's about keeping these sort of issues front of mind, how the actual Toolkit project has worked and how we've tried to collaborate with each other. We've had a pretty close-knit group, and we've dealt with these issues as they've come up at our various committee meetings, but certainly it will be interesting to see how the qualitative analysis goes in terms of what are some of those ways to overcome those barriers of getting the patient from identified into active care. So
I think you've identified that you're only getting 50%, 40 or 50% of patients identified are coming in for their fibrous scan. So that's going to be an extremely important issue in the success of the project, isn't it?
We've actually got Phoebe from CESPN online, who's managing this project, and I wonder, Phoebe, I know you've said the number in the past about you know, what sort of pickup rate we get when we run kind of projects like this, trying to identify patients. Did you have a number for stuff like that? I feel like you've told us in the past that sort of getting those recalls, we expect there to be a bit of a drop off of the number that we might like to recall than those that we actually get recalled.
Oh, sorry, Penelope, not off the top of my head. I'd have to hunt back over what I may have been referring to.
No pressure. I thought there was a number, but I think I think you could probably find similar studies in various cancer screening projects or cancer screening programs, right, where we identify the patient for recall. You know, how many people actually come back is another matter. So it's quite a complex space, I think.
How many people return their fecal occult blood?
Exactly.
All those sort of things.
That's 30%, I think, for FOBT. I think it's also worth acknowledging, we've said this in our meetings, I guess, but not to the whole group before, that it's been an amazing effort to run this in the midst of COVID. And I think the general practices have done a fantastic job kind of, you know, switching gear. You know, COVID slowed down, and, you know, we come in to do a scan, and then COVID would flick up again, or there'd be vaccination. So, you know, I think we've done a good job trying to keep going with this, and hopefully, touch wood, if 2022 is a bit more stable, we might go back to some of those people who haven't responded and try again to recall them and see how we go, I think.
With all these practical issues that are very important, and running this project in real life, it's really identifying what works and what is a problem. And that can be a big part of the, I guess, the ultimate outcome of the research.
And ideally, just a pilot, if we get good data around what is the prevalence of cirrhosis, I mean, that's not even well known in Australia, what proportion of people getting a liver cancer screening. I mean, I'd love to see personally in 10 years, we might even have a national liver cancer screening program where you registered your patient for them, and they'd get a letter in the mail and say, you need to do your do you know what I mean? Like, I just think we're so far behind cancer screening for other cancers. So this might just be a pilot to hopefully improve on, I think.
And I think that's the key here, that this is a pilot project that's being run through a small number of general practices to pick up sort of, does the tool work? Does it pick up patients appropriately? And is it a good mechanism for getting them identified and then getting them into the relevant screening and the relevant care if necessary? We've only got 2 more minutes. I'll just add a couple of comments that have come through on the chat. Janice, who's working on our project, has commented that she's raised the hepatitis results not being picked up easily through the general practice software with the Ministry of Health, and she says she thinks that they are finally listening. So hopefully it will get sorted. So again, I think, you know, these projects really highlight, like everyone has said, where our software could be working better for us. So if we've got results in our software that POLA tools cannot extract, that's not very helpful. So Janice is going into fight for that issue. And we had a comment from Anna Singer saying it was a good excellent presentation, in fact, and she's learnt a lot. The liver toolkit should be applied by all GPs. Thanks. So I think it's a nice, it might actually be a nice place to wrap up, really, and to really thank everyone who's been involved, all the presenters tonight, and the teams that have been going out to practices to run those fibro scans, and looking after the patients once they've been referred into the clinics, to all the practices that have been involved in recalling patients and working through their queries that they might have in terms of being involved in the project. And also, of course, to the CESPN staff who've been managing this project. Phoebe Tromley, the lead, work tirelessly behind the scenes to make projects like this work. So thank you very much to everyone who's been involved. And really what we'd like to do is keep you involved. So we put some contacts up there. If your practice is involved with the project and you're not really sure what you're supposed to be doing, or if there is participants who want a bit more information, there's some contacts there to get in touch. As David has outlined, there is a sort of final stage of recalling patients that is happening still. So we're still recalling some patients, but we are working towards wrapping up those recalls and moving into evaluation stages of the projects in the coming months. And so practices will be contacted, and it might be someone here on the call who might get us to participate in some qualitative interviews to talk about their experience with the project. So thank you for being involved. Please continue to be involved. And if we've taken something really important away from tonight, is don't forget about liver health and liver cancer screening, and add it to your list of things to keep front of mind, particularly when we're talking to patients who have risk factors for the disease.